So imagine you survive a massive heart attack, right? You get to the hospital, they clear the blockage, and you think, okay, the worst is over.
Right. But it's really just the beginning. I mean, the assumption is usually that once the blocked artery is cleared, the plumbing is fixed and the heart just gets back to work.
Yeah, but actually, your heart is kind of a ticking time bomb at that point. You've got these violent electrical storms first, and then a few days later, there's this terrifying risk that the actual wall of the heart might just blow out like a cheap tire on the highway.
Exactly. It is an incredibly precarious timeline. The hours and days immediately following a myocardial infarction, or MI, they involve a highly predictable yet, really dangerous sequence of failures.
And that sequence is exactly what we're decoding for you today on this deep dive. We're looking at an academic exploration of some highly specialized cardiology notes from Dr. Asifullah, combined with the current AHA and ESC clinical guidelines.
Yeah, we want to give you a shortcut to understanding this precise post-MI timeline because, you have to look at the heart not just as an organ, but as this masterful yet highly vulnerable piece of engineering.
Right, to see how the specialists actually anticipate these cascading complications. So let's start at the very beginning of this timeline. We're talking days 1 and 2.
So in the immediate aftermath, the tissue damage has just occurred. And the threat isn't just the dead tissue itself, it's the profound, localized reaction to that injury. Dr. Asifullah's notes point to something called fibrinous pericarditis as a primary example of this early inflammatory phase.
Okay, so pericarditis obviously means inflammation of the pericardial sac around the heart. But mechanically speaking, how does an injury deep inside the heart muscle radiate out to affect that protective outer layer so fast?
Well, it comes down to the sheer depth of the injury. When a patient suffers a transmural MI, meaning the cell death goes all the way through the entire thickness of the ventricular wall, the inflammation doesn't just stop at the edge of the muscle.
It just keeps going.
Yeah, the notes refer to this as infarct extension. The severe inflammatory response basically bleeds over into the pericardium. And that sac is normally smooth and lubricated, right?
Yeah.
So the heart can glide with every beat.
Right.
But now it becomes irritated. It starts exuding this sticky fibrous protein called fibrin.
Oh, wow. So the heart is essentially rubbing against a rough sandpaper-like surface every time it contracts. That sounds awful.
It is. And that completely explains the sharp pleuritic chest pain that patients report in those first couple of days.
Yeah.
But while the outside is physically inflamed, the internal electrical environment is doing something even more extreme.
Yeah, the notes highlight that within the first 48 hours, patients are at peak risk for primary electrical instability. So we're talking about ventricular fibrillation and ventricular tachycardia, VF and VT.
And those rhythms are the absolute extremes of electrical chaos. I mean,
Yeah.
in VT, the lower chambers are firing so rapidly they don't even have time to properly fill with blood.
And VF is even worse, right?
Way worse. In VF, organized contraction is completely gone. The muscle is just quivering. So hemodynamically, the output drops to zero. Without immediate defibrillation, it's fatal.
So this brings up a point in the AHA and ESC guidelines that honestly seems completely counterintuitive to me.
How so?
Well, if a patient goes into VF or VT right after an MI, the immediate reaction would logically be to install a permanent safeguard, right? I mean, if my house's electrical panels start sparking wildly and causing fires right after a severe storm, I'm calling an electrician to install a permanent heavy-duty circuit breaker.
That makes total sense.
Right. So why wouldn't the guidelines mandate placing a prophylactic implantable cardioverter defibrillator and ICD in these patients to prevent them from just dropping dead a month later?
Yeah, the instinct to install a permanent fix is strong, but you have to distinguish between a temporary metabolic crisis and a permanent anatomical flaw in the wiring. The guidelines specifically categorize this early VF or VT as primary electrical instability. See, when the coronary artery is blocked, the downstream cells are abruptly starved of oxygen and ATP. And without that energy, the ion channels on the cell membranes just fail.
Right. They can't maintain their charge.
Exactly. Potassium leaks out of the cells, intracellular calcium surges, and you get this highly volatile, arrhythmogenic environment.
So the electrical storm is just a direct consequence of the sudden starvation. It's not necessarily a sign that the heart's wiring is permanently broken.
Right. The cellular environment is chaotic because it is acutely ischemic. But once the patient is revascularized, once the doctors restore blood flow to that tissue, the surviving cells clear out that metabolic waste. The electrical gradient normalizes.
Oh, I see.
So the guidelines state that if the patient is successfully revascularized and their ejection fraction, their pumping strength recovers, this specific early VF or VT does not actually carry a higher long-term mortality risk.
Because the underlying cause, that acute ischemia, was totally reversed. And putting in an ICD carries its own intrinsic risks, right? Like device infections or getting inappropriate shocks down the line.
Exactly. If the data proves the long-term risk of sudden cardiac death isn't elevated once the ejection fraction bounces back, the permanent hardware is just unnecessary. It's evidence-based medicine kind of pulling back against the anxiety of seeing a fatal rhythm on the monitor.
That is fascinating. Okay, so if the patient actually makes it through those first 48 hours and the electrical irritability settles down, the timeline shifts.
It does. The immediate metabolic crisis gives way to a structural one.
Right, the tissue itself is changing in response to the cellular death, and the risks transition from electrical to mechanical. And to track this, Dr. S.C. Fula's notes utilize a really specific diagnostic framework, the PDAM mnemonic, PADAM.
Yeah, high-stakes clinical environments really require these cognitive frameworks. When a post-MI patient suddenly deteriorates on day 5 or day 10, physicians need a rapid, systematic method to rule out every mechanical complication. And PDAM organizes the progression of tissue degradation perfectly.
So let's break those down for everyone. P stands for papillary rupture, which we're going to dive into deeply in a minute. A is for aneurysm. D is Dressler syndrome. The second A is for arrhythmia, which we actually just covered. And M is for mural thrombus.
And looking at aneurysm and mural thrombus together is really interesting because it shows how one structural failure breeds another.
How so?
Well, as the necrotic tissue in the ventricular wall is cleared away, it leaves this thinned, weakened area. And over weeks or months, the massive internal pressure of the ventricle can cause that weakened wall to basically balloon outward into a true aneurysm.
Okay, and because that ballooned section of the wall isn't actively contracting with the rest of the heart, the blood inside that pocket just sort of sits there. It stagnates.
And stagnant blood coagulates,
Right.
which leads directly to the M in our mnemonic, a mural thrombus. A blood clot forms on the inner wall of that aneurysmal sac, and the main danger there is embolic. If a piece of that clot shears off and travels out of the heart, it can head straight up to the brain and cause a massive stroke.
Wow. And then there's Dressler syndrome, the D, which seems entirely different from the rest of the list because it's not a direct mechanical failure. It's actually an autoimmune response, right? And it shows up weeks later.
Yeah, it's a delayed complication. When the heart muscle cells die during the initial MI, they release cardiac antigens into the bloodstream. These are proteins that the immune system usually never sees.
Because they're supposed to be locked inside the cell.
Exactly. So in some patients, the immune system misidentifies these released proteins as foreign invaders, and it starts producing antibodies against the heart's own tissue. Weeks later, this triggers a diffuse, severe pericarditis.
So the body essentially mounts a delayed attack on its own damaged architecture. It's kind of tragic.
It really is.
But, as comprehensive as the PDAM framework is, the notes focus super intensely on a specific subset of catastrophic structural failures that occur within a really dangerous window, days 3 to 14 post-MI.
Yeah, the rupture window.
Right. This is when the compromised muscle physically gives way, like the left ventricular free wall rupture.
And to understand why the wall ruptures in that specific time frame, you really have to look at the cellular cleanup process. When a section of the left ventricle dies, the body sends in macrophages.
The cleanup crew.
Exactly. These immune cells secrete enzymes, specifically matrix metalloproteinases, to digest and clear out the necrotic myocytes. They literally have to clear the debris before new collagen can be laid down to form a permanent scar.
Wait, so between days 3 and 14, the dead tissue is being aggressively dissolved, but the tough, fibrous scar tissue hasn't matured yet.
Right.
So the wall is practically turning to mush, while at the same time, it's still trying to contain the immense systolic pressure of the left ventricle pumping blood out to the entire body. That is terrifying.
The mechanical mismatch is staggering. I mean, think of the left ventricle like a heavy-duty truck tire. The MI is like a spike that damages a localized section of the rubber. The tire might hold air initially, but the rubber is quietly rotting and thinning out from the inside.
And then a sudden spike in pressure, like maybe the patient just coughs or they have a surge in blood pressure and it acts like hitting a pothole at highway speeds.
Yep.
That thinned out section of the ventricular wall just suffers a catastrophic blowout. The high pressure blood blasts straight through the outer wall of the heart.
And the clinical presentation is immediate and devastating. The patient experiences rapid hemodynamic collapse.
Mhm.
And if you look at the monitor, it will often show pulseless electrical activity, or PEA.
Okay, so let's clarify PEA for a second. With PEA, the EKG monitor still displays an organized electrical rhythm, right? Like
Yeah.
the pacemaker is firing, the signal is traveling on the pathways,
Yeah.
but the patient has absolutely no pulse. Hemodynamically, nothing is moving. So if the free wall just ruptured, is the lack of a pulse simply because all the blood is hemorrhaging out into the chest cavity, like they just bled out?
It's actually more contained than that, which is what makes it so rapidly fatal. The blood isn't spilling out into the open chest. It is blasting directly into the pericardium, that tough fibrous sac surrounding the heart.
Oh, right.
And the pericardium does not stretch easily, so as this high-pressure blood rapidly fills that confined space, the pressure inside the sac skyrockets until it actually exceeds the pressure inside the heart chambers.
Oh, wow. So the blood trapped in the sac literally crushes the heart from the outside.
Yes, it is classic cardiac tamponade. The external pressure is so immense that the right and left ventricles physically cannot expand to fill with blood during diastole. And if the chambers can't fill, they have nothing to pump.
That makes total sense. The electrical system is still issuing the command to squeeze, but the mechanical system is completely empty and strangled by the fluid around it. Hence, pulseless electrical activity.
Exactly. And the intervention described in the notes for this is extreme. It's emergency pericardiocentesis combined with surgical repair. They literally have to drive a needle directly through the chest wall into that pericardial sac to drain the trapped blood just to relieve the pressure.
Just to buy some time.
Yeah, but relieving the tamponade might buy the surgical team a few minutes. Then they have to rush the patient to the operating room, open the chest, and physically patch or sew the ruptured, friable tissue shut. And the mortality rate is overwhelmingly high because sewing through tissue that has been degraded by macrophages.
So it's trying to stitch wet tissue